So our final speaker today is Katie Reeves. She's a paediatric emergency physician from Brisbane. So recently Katie was part of the pre-match ceremonies for the Women's World Cup at Suncorp Stadium, and she got to know that grass intimately. She tells me she's changed the title of her talk but not the topic.
Yeah, absolutely. Scott, that reminds me of a day that one day one of our ICU consultants came down in a flurry and was worried that his wife had broken their child's arm, and I promptly put the pulled elbow back in and said, I'll do the pulled elbows, you do the ECMO, and we'll have a happy working relationship. Hello everyone, my name is Katie. I'd like to acknowledge the Kaurna people who have been on this country for 65,000 years and pay respect to their elders past, present and emerging. I recognise that we are better together, talking and learning, and in particular acknowledge the Aboriginal and Torres Strait Islander people here today. So what we're going to talk about is streptococcus. I promise I haven't discussed with Scott about his talk, or strep, and how there's a spectrum of disease in which it presents. What I'm going to do today is I'm going to remind you about the ways in which you can differentiate, find and treat this simple yet gnarly bacteria. I'm presenting because we have a challenge when we're in diagnostic medicine, and we need to proactively think and look for disease and the spectrum of ways in which they present. I want you to deliberately consider every one of your patients, and I want you to find something doubtful or off, something fishy. Here's the thing, you can actually apply this to all aspects of diagnostic decision making, and it will keep you and your patients safer. So I work in a tertiary care paediatric emergency department as an emergency physician, and I'm in the business of undifferentiated patients. Sometimes I feel like I'm in the business of upper respiratory tract infections, which is what the vast majority of patients we see these days have. The reality of emergency in a big city is that we are seeing lots of these patients in ED, and most of them are straightforward. Fever, cough, runny nose, and a red throat. Upper respiratory tract infection, that's the norm. But I want you to consider in this world of coughs and colds that the art is not diagnosing that viral infection. In fact, it's the ones that aren't. Where are the patients with one, some or all of those symptoms of vomiting, diarrhoea, rash, red throat and fever? They're there, you just need to look. You might see this, the strawberry tongue, bumpy and swollen and red, and looks like a strawberry, of course. This is a textbook sign that alerts you to the possibility of scarlet fever. And this is often associated with a rough sandpaper rash, which covers the body. Scarlet fever, that's strep in one of its iterations. In paediatrics and in emergency, I've spent a lot of time stopping antibiotics, or asking questions about antibiotics, or justifying why no antibiotics are required. But this year, I have to say, I've pulled out the electronic prescription pad more than I ever have for penicillin for patients with scarlet fever. And one day I did it for 2 consecutive patients. Ooh. Yes, it's to prevent the complications of rheumatic fever and rheumatic heart disease, the latter of which is one of the highest prevalence among our Aboriginal Australians in the world. But it's also to prevent this, invasive group A strep. So earlier in 2023, this hit my inbox. Public health surveillance wanted to let us know that we needed to be vigilant for invasive group A strep. And by that, I mean the isolation of strep from a normally sterile site. So for example, bacteremia without a focus and its little cousin sepsis. Pneumonia, maybe with an effusion and empyema. Septic arthritis and meningitis. So why was this happening? I mean, I thought there was more strep because I was prescribing more antibiotics, but why was it so? There are lots of theories, and I'll talk about 2. One is immunity debt, so that because children's immune systems haven't been challenged by viruses while we've been busy with COVID, that they had become more susceptible to infection. The other concept of immunity theft, that the episode of having an infection, not just COVID, any virus, can interfere with a person's immune system for months and leaving them more vulnerable. No matter the cause of the increased rates of group A strep, it has massive consequences. It has high long-term morbidity burden, and there are deaths as well. So we need to be alert to the threat regardless of how it's happened. Being alert to this threat includes watching out for rashes that just are a little bit different, and I'm not sure you can tell the difference on a text message, that are also caused by strep. So this rash is fishy in two ways. It's not a typical viral exanthem, and it's not that typical scarlet fever consistency of sandpaper. It's this lovely salmon pink colour. Rashes like this that look like sunburn are more, and that they're confluent and red everywhere, can be streptococcal toxic shock syndrome. It's also caused by strep, but not necessarily associated with scarlet fever. Remember though that this is a talk about strep, but it's also a talk about diagnosis in the face of uncertainty. So I want you to remember that everything has to be taken in context, with a good history, a complete examination, a systems review, and a top-to-toe exam. Don't forget about other diagnoses: Kawasaki's disease, staphylococcal scalded skin syndrome, and PIMS TS. A lot of the diagnostic criteria overlap, so know that there are criteria, look them up, and make it part of your diagnostic checklist. So back to the talk about strep, and more specifically invasive group A strep. It can be difficult to distinguish from a viral infection. The signs and symptoms are really non-specific: fever, sore throat, vomiting, diarrhoea, headache, again, day to day in the emergency department. To find this beast, you need to take a good look, go deeper, and ask more questions. You need to get inside and you need to think, why isn't this strep or one of the other common diseases? So your history on the inside needs to include the trajectory of the illness. When did the fever start? When did it stop? Did it start again? Be alert to the patient who is more unwell than you would expect for a typical viral illness, or a viral illness that then suddenly, where they became more unwell at a time when you think that they should be getting better. What did the symptoms the parents, medical or otherwise, mean when they had a cold? Was it just a sore throat, or was it a sore throat with a runny nose and a cough? Check your systems, ask about leg pain. Have they been walking or not wanting to walk? The presence of abdominal pain and vomiting and diarrhoea. Look at the rash. Where is it? Is there sparing in some areas? What's the consistency? Is there peeling associated with it? And what is the texture? And think about other signs and symptoms that might indicate a bacterial focus, such as an otitis media, which could lead to something more invasive. And most importantly, interrogate those observations. So do your temperature, do your pulse, ooh, it's like an alert, do your blood pressure and respiratory rate, check their cap refill. I know it seems like we should do that every single time, but we don't. Give an intervention like paracetamol and check them again. So you say, oh, well, these kids are really good until they're not. They can hold their blood pressure until they have a massive reduction in their cardiac output, and that's true. But if you don't measure it, you won't know that it's normal, or you won't know that it's abnormal. And if it's normal, think about tachycardia. It can be the first indication that there's circulatory compromise and should not be ignored. I'll say that again, don't ignore tachycardia and don't ignore things on your early warning tools. They are smarter than all of us and the patient. They're together trying to tell us something. So you might do all of that and you might still not have a diagnosis, but you know something's fishy. So these are the kids that you might do bloods on. Please again be aware that there's limitations with those as well. You might phone a friend, and by that I mean a professional colleague. You might share your concern and you might have a discussion and collaborate on your decision making. You might also do the test of watching and waiting. To take things to the next level, you also need to remind yourselves that having a virus doesn't get you out of having a dual or a subsequent diagnosis of anything, including invasive group A streptococcus. So this harkens back to the immunity debt and the immunity theft theory. Viral infections damage your airways, allowing invasion into the healthy sites of the respiratory tract, and they also fundamentally impair the immune response and provide a lovely, favourable environment for bacterial growth and adherence. One thing that you can do to prevent invasive group A strep is to make sure your patients are up to date with their routine immunisations. Talk to them about seasonal flu immunisations, and if they're old enough, having a COVID immunisation, because this actually may prevent the viruses that then lead to the invasive disease. So, ladies and gentlemen, whilst there is an overlap and a spectrum of symptoms within the patient before you, with fever, sore throat and a rash, I want you to work hard on finding not only that strep, but other diseases. I want you to dive into your diagnosing, check yourself as well. Always think about other possibilities. I want you to use checklists, I want you to use early warning tools, and look up the diagnostic criteria to help refine the possibilities. Apply these and know that every time you need to look, and sometimes you actually do need to ask. Because whilst you might not have the diagnosis, you should then be able to tell that something's fishy, that you might watch or investigate or get a consult, and it's all worth looking for, and the rewards are big. I've got a little postscript to this talk, and I'm glad to see Damien in here, but I did actually do this before I saw Damien walk in. Damien spoke a little bit this morning about that patients may die of disease no matter what we do, and I think it is still important to recognise that children can still die of strep, even if you do everything that you possibly can, and even if you see them before they have their deterioration. We've had plenty of cases at our hospital where we've looked back and thought we wouldn't have done anything different, but it still doesn't feel good. And after I was allocated this talk, I actually managed a child in our emergency department who was catastrophically unwell with severe group A strep bacteremia. And I thought a lot about her. She spent 4 weeks in the emergency department and was discharged relatively unscathed. What I learned from her case was that there were few and if no delays for her. Her mum was a nurse. Her best friend was a paediatric emergency nurse that I worked with, who had been helping look after her child with the simple vomiting and diarrhoea the day before. The mum recognised the instant that her daughter had changed in colour, and they had decided to drive to the hospital, which was less than 10 minutes away, rather than call and wait for an ambulance. They arrived when I had just started for the morning. She had early interosseous access, and then had beautiful ultrasound guided vascular access, followed by POCUS directed therapy, where we assessed her volume and were able to really focus our management on her vasoplegic shock. Up in ICU later, she had an ECMO team discussing her case at the bedside before she needed it, and she was placed on ECMO very, very quickly. When I visited this family during her stay, her mum and I commented on all of these serendipitous moments, the perfect timing, and that had meant that they could hold their child again in their arms, and how lucky it all felt. We've celebrated that win, but I doubt that it will ever be perfect like that again. But you've got to keep looking. You've got to keep looking hard. This disease is bigger than you, but it's nice to feel that you wouldn't have changed a thing if the outcome is not so perfect. Thank you.
Thank you, Katie. Does anyone have questions? Got some hands up, Ben? Yep.
Thanks so much, Katie. I'm Lucy. I'm a PEM AT from Sydney. I was just curious about the potential mechanism of what some people talk about almost like spread of group A strep, which doesn't make any sense to me, having always known bacteria are often secondary to viruses, and viruses spread like wildfire. So I've got a child I saw in the ED a few weeks ago who had moderate periorbital cellulitis, that burnt rash, a CRP of 260, and a very red throat and tongue. So presumed group A strep, and his parents said his sister had had a group A strep throat infection 3 days prior. And I just didn't understand, and still don't, why one might lead to the other in the household. Or is it just a chance?
Is it a question about that it can be transmitted between household contacts, or is it the question about why one child gets a more serious or invasive illness and the other one doesn't?
The question is, can it be transmitted?
Yes.
Is that a known mode of action?
Yes, it absolutely can.
Right.
I'm no microbiologist or infectious diseases doctor. It was very interesting, that patient that I had seen, the next day mum came and said, I've got a skin infection on my finger. And it was hard because she was a medical mum. Her child was upstairs on ECMO, and mum also told me that and it was really hard, but actually I looked it up and yes, that's true. Her brother also had otitis media at the time. So I believe that's, you can swap it around within the family a little bit like a virus. And if there's anybody who is got a bit more information about that, I'm happy to talk.
Yep. Not that I'm an expert in microbiology.
No, neither is.
We had a very sad case recently of a child who actually died from invasive group A strep, and I was involved in the Reeves analysis. And it was really interesting because I got a call from the micro lab, and they were, wondering who's going to inform the family. And then I started looking up RCH guidelines, and it's really interesting because I spoke to the public health in Queensland, and I think we're still learning a lot about it because in Queensland, the guidelines isn't that if someone has that invasive group A, you don't treat the rest of the family members. But then in Victoria, if you look at the RCH guidelines, it says you treat them, I think, with 10 days of Kefka. So I think it's still a really evolving area.
So that mum got treated. That mum got treated by her specialist, like the specialist that, that boy came in and we all completely understood that he had a vaguely sore ear, and I said, can have intravenous vancomycin if he wants at the moment. You know what I mean? There was no doubt that a whiff of infection was going to get treated because that was because of the situation.
Hello. I was wanting to ask with the strep, given there is so much strep going around at the moment and everyone has either had a patient, I've had a family member die from it, how do we stop the reflexive, see every ERTI terrified that it's strep and give everyone antibiotics?
Yeah. I'm very sorry about your family member. It's a terrifying disease and that little cloud sits over your head, I suspect. Look, it's really hard. I guess Scott spoke to that a little bit now, and Denny says that they've had a case, and so we're all very aware of that. I just think you have to be objective each time. You need to check yourself. So the week after I looked after that little girl, I just saw it everywhere. I was like, they've got bacteremia, and I actually announced it to my little team. I said, mate, I'm seeing strep everywhere, but I know it's common, so I might be doing blood cultures a little bit more. So just sort of moderating it, being aware of that bias is important, but also being objective in the things that I discussed before for every patient, medical, non-medical, otherwise, so that you've got that strategy each time.
Thanks. Can I ask first if there's a paediatric cardiologist in the room?
Oh, that would be nice.
There is one, yes.
Oh my
okay.
goodness,
So I can.
Yes! Yeah.
That was just because I now can't make my comment about who makes the worst doctors of children who have chest pain.
Can you ask it anyway? Because I'm hoping you asked what I'm thinking you're going to ask.
Oh, no, I'm not. I was literally just going to say that the worst parents are paediatric cardiologists who have children with chest pain by an absolute country mile. But kind of going back to the topic in hand, my understanding is that kind of because of the unique way that streptococcus can be carried in respiratory droplets, if you have it in your throat, it can be transferred, but that's unique to streptococcus, which isn't the same for other bacteria. But The problem is that 20% of children at any given time carry it. So there's a huge debate in the UK about whether testing is any use or not. People swear by it because it helps them make a decision, but it doesn't necessarily mean you're actually treating streptococcus that is symptomatic. So we made a decision, rightly or wrongly, to reduce the threshold for treatment in November of last year, so that if you had a fever pain of 2, you could get treatment. What that subsequently meant is that we ran out of antibiotics.
Well, we've had exactly
and then that caused us an absolute challenge as well. So there's no good answer at the moment.
No, so we've had exactly the same experience. After a few cases, we all said we're going to have a lower threshold for swabbing throats. I never used to swab a throat. I'm like, I'm going to treat it, or I'm not going to treat it, or I'm going to call it viral. And then we've also run out of antibiotics at the moment. Then you run out of one, then you go to another one, and then you run out of that one, you go back to the other one. It's really hard. It's really hard in this time where I find everybody is worried after COVID. There's this higher level of anxiety in the community about everything, not just viruses. And then we've got these other threats coming up because of COVID or otherwise that are bothering people. So look, it's a really hard thing. I hope that my talk really was talking more about being suspicious about something fishy when a pattern doesn't make sense, irrespective of if it's a virus or if it's the strep or if it's this or if it's that. It's more being vigilant in a time when it's difficult for whatever reason to think about those things, be objective and have a broad differential.
Yeah, hi, Leanne. I'm a general paediatrician in Queensland. More a comment than a question. Thank you for 3 excellent talks about the spread of Group A strep. Certainly, recently I've had a number of cases of invasive Group A strep patients. One was a neonate, 8 hours of age. The neonate actually became febrile at about 8 hours of age. Mum looked awful but didn't become febrile until 24 hours of age, 24 hours after delivery, and the baby had Group A strep. I spoke to the micro team about that, and the question was about prophylaxis in contacts. And they said, the microbiologist I spoke to has said she'd had 4 cases in the last week of invasive Group A strep in mums that hadn't transferred to bubs, but all the bubs were receiving prophylactic antibiotics. So it seems like it's becoming a bigger thing. I haven't seen Group A strep for a long time. I had a case of Scarlet fever last week. And, you know, I think there's certainly the move towards prophylaxis in Queensland now.
I think really important there to recognise that neonates are a very special, you know, a special vulnerable group. So your threshold may be very different. But I think perhaps that's the learning point here, is that you can catch it in families and transmit it around, and it depends on the context, of course, and what the kid looks like, because not every kid will get that. This girl's brother had I don't think his eardrum looked anything like that one that Scott showed us. Yeah, no, I know, but that mum was really worried, and the ear was like, I'm like, I don't even think it's red, but you can have some antibiotics because you know, ECMO. Was there one more?
Yeah, we've got one more.
Hello. Hey, thank you. Thanks for 3 really awesome talks. Just going back to the Group A strep comments and questions, I guess with the airborne transmission of Group A strep and the higher rates of rheumatic heart disease in New Zealand, as is in the case for Aboriginal Australians here, New Zealand, I don't know if anyone's aware of the Porirua sore throat protocol, which we use in New Zealand, Aotearoa, which includes your Indigenous status as part of the decision tool. So really important just to point that out, and I think in Australia it'd be amazing to see that incorporated in like national guidelines.
And I remember last year at Don't Forget the Bubbles that we had a talk on, there was a lot of focus on rheumatic heart disease, and that was really good because it just reminded me every Indigenous child with skin scabs, every Indigenous kid with a red sore throat, you can make a difference. It's hard when you're seeing non-Indigenous populations get very devastating aspects of disease.
We do have time for maybe one more question, 1 or 2. I can see a couple of hands.
Hi there. The UK's had a very gnarly winter just gone with Group A strep, which I'm sure many people have seen in the room, and it was widely reported in the press. I had certainly lots of non-medical friends keeping their kids off school because they were so scared about this invasive groups, especially in Scotland, I think. Is there any evidence, if anybody knows in the room, whether or not this is a global phenomenon demographically? Are things changing?
Like that it's more common everywhere.
It is.
Well,
So
I mean, this is my point, is that we're seeing it everywhere. I'm giving antibiotics out like lollies at the moment. So I think we've all discussed that that's very much the case. And is it because we've got immunity debt because of the viruses? Is it because we've got immunity theft? Is it because we just don't want to take any risks in this world anymore after a really torrid couple of years? I'm not sure. It's fascinating.
Just one more at the back, I think, Ben.
I was just going to say, Michelle and Tara on the community is a very deep part of public health and has been for a really long time. So really important to keep the low threshold for Strep A, particularly in rural communities.
Yep, absolutely. Thank you, Angela. Angela's our Indigenous. Very important, very important.
Okay.
Thank you.
Thank you, Katie.